and I wrote this paper. It's called My Greatest Fear About My Greatest Fear. While I am well now, I fear dementia above all other diseases. In the early stage of the disease, beyond my embarrassment about forgetting and my frustration to accomplish tasks that I previously found easy, I fear feeling alarmed as I no longer can deny that I am observing myself beginning to lose my mind. My most treasured organ is my mind. It defines who I am. Thus, the challenges of early dementia are more than inconvenient. They will fuel my anticipatory fear by heralding greater future losses. My values will change as my dementia progresses to the middle stage, but it's likely that I will still be able to enjoy some of life's simple pleasures, and more importantly, respond lovingly to my significant relationships. I thus now judge as best I can that the benefits of continued treatment will outweigh its burdens for the early and middle stages of dementia. But when I reach the stage of advanced dementia, I will manifest an asagya. That is, I will no longer be aware that I suffer from the disease. At that point, I must confront this cruel joke, this fear. I am not afraid of dying, I just don't want to be there when it happens. And to explain, my body will be there to suffer from pain and multiple other burdens, while my mind will not be there. Not there to appreciate my condition, its prognosis, and how it affects others. Not be there to competently direct my physician and others not to prolong the process of my dying. My greatest fear about my greatest fear is that others will fail to honor my advanced care plan by which I diligently specified when I do or do not want what treatment. So let me explain my last wishes, my plan, and the basis of my fears. These are my last wishes. I want my designated proxy and my future physician to compare my future medical and mental condition with the criteria I previously selected. By a process called shared decision-making, my physician and proxy or agent can determine when I would judge that continuing life-sustaining treatments will only prolong the process of my dying and increase my risk of additional suffering. And when, in my opinion, as I have judged it, have become a huge burden on others who, despite their efforts, cannot significantly improve my functioning for a sustained time, while I have no ability to appreciate the sacrifices that they are making on my behalf. My plan includes natural dying by foregoing not only the usual kind of ICU life-sustaining treatments, but also by the use of another person's hand to assist my oral feeding and my taking in fluid. I do not want to allow, I do not want food or fluid withheld. Instead, to allow for the even remote chance that I can eat independently, always offer me food and fluid by placing it near me while I'm awake. But do not assist my eating and feeding. As I undergo medical dehydration, if my mental functioning should suddenly improve enough so I can again understand how to use a spoon and how to use a straw, then I will be able to eat and drink independently. But more likely, my mental functioning will not improve, and I will die peacefully within 2 weeks. Others can consider my cause of death to be the devastating brain disease from which I suffered, namely a terminal illness called advanced dementia. My greatest fear includes 3 contributing fears. First, my healthcare providers, caregivers, or loved ones may be typical members of our food-loving culture who fail to realize that advanced dementia is a terminal illness, and that as my body dies, it is natural for it to stop wanting or needing nourishment. I fear that they may make this wrong assumption. If he can swallow, he must want to swallow. Their good intentions may lead to actions that border on force feeding, actions that will prolong my dying, and actions that may directly and indirectly increase my suffering. My second contributing fear is that others will misapply Pope John Paul II's 2004 allocution, reaffirmed by Pope Benedict XVI, which states that in principle, patients in the persistent vegetative state must be provided the ordinary basic care of tube feeding. But advanced dementia patients are not stable like PBS patients. In fact, dementia is the 6th most common cause of disease. Also important, advanced dementia patients can experience pain and suffering. They are not unaware like PBS patients, and they are not unconscious like comatose patients. Although I'm not Catholic, I may be a patient in a Catholic hospital or a resident in a Catholic skilled nursing facility. I thus now judge that for the condition of advanced dementia, the following is consistent with Catholic teaching, and I use phrases from the U.S. Conference of Catholic Bishops, Ethical and Religious Directives, 5th edition, 2009. I quote, "may reject life-prolonging procedures that are insufficiently beneficial or excessively burdensome." In the introduction, I may forego extraordinary or disproportionate means of preserving life. That's number 57, Ethical and Religious Directive. And certain measures to provide nutrition and hydration may become excessively burdensome and are therefore not obligatory in light of their very limited ability to prolong life or provide comfort, ERD 58. My third contributing fear is that my future physician will override my diligent advanced care planning by using one of the forms in the PULSE paradigm. That's the physician's orders for life-sustaining treatment. My informal review of 30 endorsed or developing programs in 30 different states that I did in May 2012 revealed that only one did not mandate the offering of food and fluid by mouth if feasible. About 2/3 of the forms use the word always or must or both. And either the standing orders under artificial nutrition and hydration or in the embedded series of orders under comfort measures only. Very significantly, no post-paradigm form has a box to indicate that a choice about this kind of feeding, eating and drinking with assistance from another person's hand, that you can make a choice about that treatment, and it's possible to choose it or not choose it, and that it is even worthy of discussion. No box to check, nothing to discuss, it's just there. Furthermore, post laws and regulations give physicians power and leeway to select a co-siding, legally recognized decision maker. So what do I fear is that after I lose capacity, I will be at the mercy of a physician who selects, but is totally, by the form, discouraged from informing this surrogate decision maker that she can forego, on my behalf, assisted feeding and drinking. Also, according to the majority of the PULSE laws and regulation that rule them, the newly created PULSE will override my old advanced directive. This is always the case in Idaho, North Carolina, and Utah, and in other states, the most recently completed form rules in California, South Carolina, and Washington. But just the standard of practice is if you see a physician's orders, you do what the orders say. That's just an assumption that many people can and will make. So, the only state that was different was the state of Tennessee, which states in their statute that the advanced directive would prevail if there's a conflict between the PULSE form and the advanced directive. So my fear is that after I lose capacity, my future physician and my uninformed, legally recognized decision maker that my physician selects will together take the course of least resistance. They will accept the strongly worded post-mandated order to offer me food and fluid by mouth. They will not take the more courageous, diligent, and course that respects my autonomy, my right to self-determination by honoring my advanced directive. As someone who professionally counsels patients engaged in advanced care planning, I've become aware that how some patients deal with the uncertainty about how durable their wishes will be by opting for what is known, what I call premature dying. Very typically, this is expressed by the sentence, if I don't kill myself now, I won't be able to kill myself later. I feel sad when I read about patients who do this. For example, Dr. Kevorkian's first quote-unquote patient, Janet Atkins, had an early or middle stage of dementia in 1994 when she died with his assistance. And at trial, experts testified that she could have probably lived another 3 years with reasonable quality of life. When patients opt for premature dying, they violate the sanctity, or if you prefer, preciousness of life. And they add an additional and unnecessary tragedy to their diagnosis of dementia. And the reason why it's unnecessary? Because there is an ironclad strategy so that you can die when you want instead of when you can. My greatest fear about my greatest fear is that others will not honor my wish to continuing the treatment of assisted feeding and drinking if I reach an advanced stage of dementia, when it will only prolong my dying as it increases my risk of more pain and suffering, as it extends the burdens of my loved ones. Any person who overrides my clearly and consistently expressed wishes because she thinks it is cruel to deny me food and fluid, or who misapplies a religious teaching that is relevant to another disease, or who uses a post-paradigm form, the physician's orders for life-sustaining treatment, and a post-conversation that fails to inform the selected surrogate decision maker that she does have a choice, and that can be discussed, will violate the two most venerable principles of ethics. The principle of informed consent that continues with the honoring of decisions thereby made, and the principle of medical ethics, first, do no harm.